So more exciting are the efficacy data that emerged from this trial. We see improvements in muscle size, muscle strength, and functional outcome, that being the 6-minute walk test, which is an accepted quality of life measurement.
Hello, everybody. My name is Jose Navarro Betancourt, and I am the scientific director of quadraScope. We invest in healthcare companies developing pharmaceuticals, diagnostics, software, equipment, and devices, enabling biological age reversal, disease treatment, prevention, and longevity. And today, I will have a conversation with Dr. Hans Keirstead, the Chairman of Immunis, one of our portfolio companies. Hans, thank you again for taking the time to speak with me.
Very happy to do so. I love your audience.
So we had an interview over a year ago, and perhaps a quick reminder would be useful. So would you please remind us of Immunis, of your mission, and the diseases you're targeting with your lead asset, Immunome?
Immunis is a clinical stage biotechnology company developing human cell-derived secretomes to address age-driven immune dysfunction. Our investigational secretome product is Immunome. It's being tested in a phase 1/2A clinical trial currently. It's almost over, for its ability to ameliorate muscle atrophy in elderly patients that are immobilized. And we use knee osteoarthritis as a means of immobilizing them. So they're elderly, meaning 100% of them are losing muscle, and they're immobilized, meaning 100% of them are losing muscle a little bit faster. So it's quicker for us to measure. We've published preclinical data demonstrating that Immunome builds muscle and functional muscle benefit, while also benefiting metabolism and promoting fat loss. But in this study, in humans, we have to pick one thing as a start, and so we are looking at muscle.
Now, there's a lot to unpack here, and these are all very relevant topics: muscle atrophy, aging, metabolism. But let's go one by one. First, let's talk about what's a secretome. This is everything a cell produces, correct?
Yes, that's right, a secretome.
So you basically harvest all both the exosomes, the soluble factors that these immune system progenitors produce, and then that's the product, a cell-free injection.
That's right, and specifically targeting the immune system. So we're using a cell population that produces every single factor relevant to immune system development and health. It's very much akin to what you're producing when you're making your immune system. So here we have human immune progenitors making a soup, 440 factors, a secretome that causes tremendous benefit to the immune system. So that is our primary target.
Sounds good. Now let's talk about two recent awards that Immunis received, the Global Health and Pharma Awards. Congratulations, by the way.
Thank you.
So the first award is an Innovation Award for Age-Related Disease Research and Development. And the second award was the Immune Dysfunction Treatment Developer of the Year. So why is the immune dysfunction so significant in aging and age-related diseases?
Well, you know, a functioning immune system is necessary for our health. Aging results in a decline in immune system functions and all of its associated secretions, such as beneficial proteins, lipids, and growth factors that cause the functioning and health of the immune system. That means the crosstalk between the immune cells. That means DNA repair molecules. That means the extracellular matrix that causes the immune cells to roll through tissues, because 80% of your immune system is not in your blood, it's in tissues. So all of these things are the secretome. All of the secretions are collectively known as that secretome. And so they provide the essential cell stimulation and crosstalk to promote health. And immune dysfunction plays a critical role in aging and age-related diseases by impairing the body's ability to fight infections and repair tissues. So that can lead to chronic inflammation and increased vulnerability to disease. So addressing immune dysfunction with beneficial secretomes is widely thought to be vital for improving quality of life and extending human health span. To date, we've just never had such a thing. Immunis is the first time that we have actually had this at our disposal to test.
You mentioned a very important concept, chronic inflammation. Chronic inflammation is a hallmark of aging. So how does chronic inflammation contribute to muscle atrophy and to metabolic dysfunction, obesity, and all these bad consequences?
Thank you. The immune system is fundamentally tied to muscle growth and muscle death, and it's fundamentally tied to metabolic enhancement and metabolic decline. So chronic inflammation, it's commonly associated with aging. It disrupts the normal cellular functions and directly accelerates muscle degeneration and metabolic imbalance. This inflammatory state in the aged leads to muscle atrophy, it leads to insulin resistance, it exacerbates metabolic dysfunction, and contributes to the frailty seen in older adults. Chronic inflammation does that by decreasing its own production of pro-regenerative factors and increasing the production of anti-regenerative factors, a phenomenon that we've seen in both rodents and humans now.
So essentially, acute inflammation is the good inflammation, if we can call it that way, that what helps us to repair the tissue. But chronic inflammation is really detrimental.
Very well said.
Tissue, and obviously causes muscle atrophy.
Yeah, very well.
Now, talking about muscle atrophy, specifically on your clinical trial to treat muscle atrophy associated with age and immobilization. Would you please tell us about the design of the trial? I understand different doses were tested, and perhaps some of the preliminary results.
Yeah, happy to talk about that. Our objective of the study was to evaluate the safety, the tolerability of the drug, but of course also the efficacy of the drug, Immuno, in addressing muscle atrophy in elderly patients. Again, with knee osteoarthritis, although we're not directly treating knee osteoarthritis, we're using that as a method of immobilizing the patients so that they have two insults that lead to very quick muscle atrophy, one being age and the other being immobilization, the knee osteoarthritis. So our unpublished results from the first two cohorts of patients, the first cohort received half the dose that we figured that was going to work when we translate from rodents to humans. The second was double that, so 100% of what we figured would work in humans based on the rodent data. And then the third cohort was 200%. So it was basically a doubling every time for the three cohorts. We've now finished dosing all cohorts. We've got the data from the first two cohorts. And what they show is without exception, an excellent safety profile in that no adverse events were noted, nothing associated with Immuno at all. But more exciting, of course, is we hope that safety would occur. Theoretically, we supposed it would, because this secretome we're putting in is just like the secretome that you had a whole bunch more of when you were 27 years old. And after 27, you decrease the production of this throughout life. So we're putting in the same thing, so we didn't think there would be a safety concern. Of course, the greater question for us was, does it work? So more exciting are the efficacy data that emerged from this trial. We see improvements in muscle size, muscle strength, and functional outcome, that being the 6-minute walk test, which is an accepted quality of life measurement. We also see that the chronic level of inflammation in these patients is decreased by about a half. Pain is decreased by 50 to 70%, and deep blood analyses show several very, very beneficial effects, such as the almost elimination of blood markers of cartilage degeneration, which of course KOA has a lot of. KOA patients have a lot of cartilage degeneration and pain as a result of their chronic inflammation. Because Immuno decreases inflammation, it's decreasing the pain, it's decreasing the cartilage degeneration. So we've seen that Immuno causes this dramatic betterment of functional motor ability in humans. And that's certainly the biggest benefit in the eyes of the patient. They can stand up, walk, run, dance. But as a scientist, I have to say, I'm most excited about the decrease in chronic inflammation. As chronic inflammation is just, ubiquitous, it contributes to virtually every manifestation of aging or disease. And I think we'll continue to see physiological benefit as we look at different systems. like the brain, for example. Chronic inflammation in the brain happens to every human, and inflammation in the brain facilitates cognitive decline, Alzheimer's disease, Parkinson's disease, multiple sclerosis, and a host of other neuroinflammatory conditions. So I'm deeply excited to test Imuna in several other clinical trials in different patient populations.
Yeah, that is indeed very exciting. It's one of the uh, advantages of all these longevity companies is that there are so many diseases related to the core mechanisms of aging that you essentially can have a so-called pipeline in a pill and target different indications with the same product.
Yeah.
But let me ask you a little bit about the how this treatment is it's dosed into the patients. So are you looking at an injection into the muscle a few times a week? How would patients benefit from this? Well, what would a patient expect to receive if they take Immunome?
Yeah, I'm afraid that the way that this will be administered once it's commercially available, it's probably a lot different than the way it's been administered in the first phase 1/2a clinical trial. You see, in a first in human study like this that we're just completing now, we dose in order to maximize the benefit in whatever system we're studying. So because we're looking at muscle atrophy, these are patients who are elderly that can't walk and move because of the knee osteoarthritis in any way close to what they did before they had knee osteoarthritis. The biggest effect is on their thighs, and their leg muscles of the thigh decreases by about a third within 6 to 8 weeks. It's pretty phenomenal. So in order to see an effect, the greatest, we directly inject into the muscle twice a week for 4 weeks. And the effects that we see are just increasing over time. In fact, for 3 months after the injections. So it's amazing that what we're doing, although we're maximizing the effect rate in the muscle, we're actually seeing whole body effects. That's to be expected. It's also what we saw in the rodents. You can think of a muscle as a very leaky bag. It has a wrapping around it, but it's highly vascularized and the wrapping is leaky. So when you can inject into the muscle in order to maximize the effect of your drug on muscle, but it's going to leak everywhere. So we did see, for example, an increase in size of the injected leg by 6%, but the other side grew by 2%. Now, this is not a reduction by 1/3, but rather a cessation of shrinkage and actually expansion. So these patients without exercise are actually growing muscle, but we do know that it's systemic. It's getting throughout their body. But to answer your question directly, in this phase 1/2 study, in order to maximize the benefit, we're injecting into the quadriceps muscle twice a week for 4 weeks. Now what we'll do that we know that it's working in our phase 2 studies, which I'm happy to talk about if you'd like, we are actually going to move to less frequent, once a week instead of twice a week. We're actually considering trying subcutaneous, just under the skin, instead of directly intramuscular, because intramuscular hurts a little bit more when you're poking into muscle, as opposed to pinching your skin and just going underneath the skin. So this is a very common approach for pharmaceutical companies. In the early studies, you dose a whole lot, very frequently, heavy doses, right into the organ that you want to measure, only one, even if there are organs like muscles all over the body, you inject into one to try to see it. But as you see the signal, if you're so fortunate like we are, then you start backing off the dose regime in order to make it much, much easier on the patient. So I think that this will eventually, by the time it's commercially available, it's going to be either a subcutaneous or even inhaled, or just a at-home administration of a needle, probably once every 3 months, but maybe have to be more. What we do now is we step off the twice a week for 4 weeks. We step out of the muscle, make it a lot easier for the patient experience. But
Thank you for the,
yeah,
sorry?
at the worst, it's twice a week for 4 weeks.
Well, it doesn't sound that bad.
No,
But
it's not bad.
but as you said, is if the effect is systemic, And as since you have measured all these circulating cytokines and then chronic inflammation at the whole body level,
Correct.
it makes sense that you shouldn't need a local administration.
Correct. Yeah.
And now let's you mentioned the plans for a phase 2 clinical trial.
Right.
So this trial, all the patients have received the dose. So what's next?
Well, this is really binary. After you finish a trial like this, it's either dead because the drug didn't work or it works. And I'm very, very happy to see this thing living. The results have been phenomenal so far, perfect safety and better efficacy than we could have hoped for. So we've already drafted 2 phase 2 studies to follow on from this successful phase 1/2A. One of the studies will continue with the same population, elderly patients with knee osteoarthritis. That's the safe thing to do. But of course, we want to expand the patient population because we know from our rodent works that it benefited both muscle and metabolism. So we've decided to run a second phase 2 clinical trial to explore the efficacy of Imuna in patients with sarcopenic obesity. And this is an adaptive trial design that assesses whether Imuna burns fat and builds muscle in humans, as we've shown it to do in mice. Our phase 1/2A data shows that it builds functional muscle in humans, but this will be the first time that we additionally see if it burns fat. These phase 2 studies will be double-blinded and randomized, so we're going to provide greater confidence. And we'll also be looking at a lot of biomarkers in the patient's blood to explore broader changes in inflammatory marker expression.
So obesity is clearly a major topic. Maybe to give a little bit of flavor, in the summer of 2021, the FDA approved Wegovy for chronic weight management, which is another way of saying to treat obesity. And this is the first approved treatment for obesity since 2014, in 7 years, essentially. Yeah. Now, over the past 3 years, the field of obesity therapeutics has bloomed, has become increasingly competitive. I understand that you've first started looking at obesity in mice, and this Imuna improved both metabolism and muscle function.
Right.
Now, since evidently muscles are important tissues for metabolism because they use energy, to what extent does an improvement in muscle function explain the metabolic effects of Imuna?
Yeah, it's a great question. Immuna's metabolic benefits are very closely tied to the improvement in muscle function. Enhanced muscle function will increase overall metabolic rate, and that improves glucose uptake, promotes a healthier lipid profile, providing significant metabolic advantages. However, Imuna contains about 440 factors, several which are known to work directly on metabolism. So theoretically, as we have not conducted the trial yet, Imuna would work to benefit metabolism two different ways: by directly intervening in metabolic pathways, and then secondly, by bettering muscle, which causes a betterment of metabolism. And your discussion of the GLP-1s, all of the competition has been these agonists of different flavors, basically, of GLP-1s, and they don't build muscle. Now, they just definitely burn fat. They do that. But about 30% of their weight loss is due to muscle loss. So here you're burning fat. That's good. But unfortunately, you're burning muscle. That's very, very bad. And particularly in older populations, 50 and above. By the time you're 50, you do not want to be losing your muscle. The mortality and morbidity associated with muscle loss is extreme. So using these GLP-1 agonists to burn fat is having wonderful success, and that's the 2 to 5 billion a month, the best-selling drug in human history, and warranted. But unfortunately, what's come of this is this realization by doctors and patients that the muscle loss is fairly extreme. Think about it if you're trying to lose 40 pounds, 20 pounds, 1/3 of that being muscle. Think of how much muscle you have. 1/3 muscle loss. That's extreme. That's going to have a whole lot more detriment to chronic use than frankly age will in the same period of
Yeah,
time.
and you mentioned a very specific term, the term sarcopenic obesity. Most older age patients who are obese, they also have sarcopenia. And obviously, an older person, once they lose muscle, it's very, very hard to gain it back, even if you train and
Correct.
if you do everything right. Right. So essentially, this population of patients would be the ones that would benefit the most of these muscle preserving treatments, correct?
I totally agree. Like when you look at the interplay between your immune system and muscle growth, when you're young and you work out for 1 hour lifting some set of weights, your muscle grows a lot. When you're older and you work out for the same hour lifting the same weights, your muscle grows very little. That's because your immune system is decreased. Your immune system directly triggers what's called satellite cells. They're like, think of them like a stem cell within the muscle. They can only make muscle, so they're not really a stem cell, but they are the early precursors that birth your muscle. And they are turned on and turned off by your immune system. So what Immuna is doing is creating a better immunological environment to trigger growth of muscle. So yes, it's going to be of immense benefit to the aged, but no less benefit to the young. Young people also want to decrease fat and have better muscle and therefore more energy, better cognition, and all of the downstream effects of having lots of good muscle. So I think it's going to be of use to all ages. For example, GLP-1s are being taken by all ages right now. But I think that you're right in that the greatest benefit is going to be in the aged, where muscle preservation is just so much more paramount. And metabolic decline is so much more detrimental to one's health span and lifespan.
And a second thing you mentioned on this upcoming clinical trial is that it will be an adaptive design, right? You will measure different outcomes, and obviously this is important because the reason we treat obesity is it's nice to lose weight and have muscle, but one of the outcomes that doctors really care about is preventing comorbidities. You are preventing heart attacks, you're preventing strokes, and all of these very serious diseases. Am I understanding correctly that you will also look at the potential of Immuno to stop these adverse events?
Yes, that's right. Yeah, we will be looking in this trial in both several measures of muscle growth, several measures of metabolism, from fatty lipids in the bloodstream to energy expenditure to fat reduction, both the number of cells and the size of the cells, glucose uptake, a lot of outcome measures that fall into those buckets of metabolism and muscle. Whenever we run a trial, we also allow patients to self-report on benefit as well. So we'll be asking them a whole lot of other questions that have to do with their energy levels and willpower and drive and that type of thing.
And I have to ask, how will the recruitment process be? Will this trial happen in the US? And does someone get access to this? 'Cause I imagine
Yeah,
it's interesting for many people.
yeah, we're going to be running it in multiple hospitals. So
Okay.
each of the two phase 2 clinical trials will be run in multiple hospitals, likely 4 to 6 each. And we will be advertising on our website when recruitment is available with the precise patient inclusion exclusion criteria. And we've already identified the hospitals and are in mid-stage and kind of like late-stage discussions. And I have to say that the receptivity has just been extreme. We have groups reaching out to us in order to run our clinical trials in their sites. There's no side effects. The drug is theoretically and practically, with evidence, very, very safe. And now that we have this evidence of both metabolic and muscle data from preclinical and now human data, The interest has been pretty extreme. I really don't think we're going to have any problem whatsoever in recruiting patients.
Yeah, it seems so. If people are asking you to do your trial in their hospital,
Yes.
I guess,
Yeah.
I guess it's a couple hundred patients that you.
Yeah, we will be treating several hundred patients between the two clinical trials. Yeah. Very good data sets, double-blinded, randomized, et cetera. So very excited to get onto this deeper level of, certainty.
Very, very cool. Now we just covered that the next wave of obesity treatments will be muscle preserving interventions, and since
Yeah.
all these incretin mimetics have the side effect of weight loss.
Yeah.
And I would like to discuss two emerging approaches to obesity in this aspect. The first one is it's exerkines, and the second one is anti-inflammatory drugs. So for a bit of context, exerkines are, or exercise cytokines, are signaling molecules released in response to exercise. So basically, we're trying to give patients the benefit of doing exercise, even if they can't, or they don't have the time, or they don't want, or any number of reasons. So these signaling molecules, exerkines, might be produced by muscles, but also from other organs or systems, like obviously the immune system that circulates throughout the body. Have you looked at exerkines in Immuno that has hundreds of factors?
Yeah, we have. Exerkines are part of the secretome of multiple cells in the body, part of what you can think of as a crosstalk mechanism between a variety of tissues like fat and muscle, like muscle and brain. With several components having been identified to be part of such crosstalk, it's very clear at this time that the effect of exercise cannot be attributed to a single molecule. So Immuna contains many of the exerkines and crosstalk systems, but more importantly, can direct secondary pharmacodynamics as produced by physical exercise. And this was demonstrated in preclinical studies in vitro, where muscle and adipose tissues were exposed to our product. And in fact, in our clinical trial, when we compare immunotreated patients to non-immunotreated patients of the same age, but those patients had 6 months of exercise, Immuna outperforms 6 months of exercise in functional 6-minute walk test. So not only does it grow the muscles and make them stronger, but functionally, Immuna outperforms 6 months of exercise on functional walking tests. So to your point.
So you're basically tricking the muscle into thinking that it somehow the whole body exercised at some point.
Correct. Yeah, because that's what happens when you exercise. It's a fundamental effect on betterment of your immune system. Immuna is a way of getting that to people who can't exercise or have trouble exercising or not exercising enough, causing a whole body system-wide benefit of exercise, which is muscle strengthening, which is betterment of metabolism, several other theoretical benefits of normalizing an immune system, benefits which we've seen in mice but not tested in humans yet, like reversal of arterial stiffness, like neuroinflammation, like a betterment of wound healing, like restoration of the adaptive immune response that's otherwise lost in age. So bettering the immune system does a whole lot of things, and one of them is mimicking the betterment of exercise. We certainly capture that.
And at the risk of going off track here, say someone who's 35-year-old and exercises and wishes to take these kind of drugs for performance enhancement. Maybe you have heard of them, of Peter
Yes.
Thiel's enhanced games. Would this be one of the treatments that these kind of athletes will consider?
Absolutely. Like, of course, we've not tested it on healthy normals in a clinical trial setting, so I can't say with certainty, but my goodness, like, I think everybody will be taking this. It's, bettering your immune system, calming it down, stopping that chronic pro-inflammatory response that happens in every human. You're at your peak at 27 in humans. Every day after that, you have a decline in your immune cell function and immune system function. So keeping that healthy, bettering it, is of course going to do the obvious things like make your exercise and metabolic tweaking better, right? So if you're exercising to get muscles and exercising to lose fat, then being on Immune is probably going to increase that. But it's also going to do a whole lot more, like prophylactically stave off the manifestations of immune decline, which are virtually every symptom of aging and disease. So it would behoove us to make sure that our immune system is stronger. And Immune is one of the ways that you can do that. Yeah, exercise is another. It benefits your immune system, but you can't get enough of it. With age, your exercise cannot restore your immune system. The other way around works because the immune system controls muscle development. So highly, highly influences it. So you better the immune system. Now you're bettering your muscles, you're bettering your metabolism, your arterial stiffness, your neuroinflammation, your wound healing, your adaptive immune responses. And one only has to think about the worst off, like cancer. And did you know that cancer requires a necessary precondition? There's no cancer patient that has ever had cancer that doesn't have this necessary precondition. And that necessary precondition is a challenged immune response. You only get cancer with a challenged immune response. So let's stop challenging our immune system. Let's keep our immune systems healthy so we can stave off manifestations of age-related diseases, cancer, Alzheimer's, Parkinson's, MS, all diseases, except, of course, strictly genetic errors that cause a disease without the immune system being involved. Those are few, but they would be an exception that Immune probably wouldn't help unless there was a downstream deficit to the immune system. Then Immune would probably be able to help it.
Well, this goes back to the whole neuroscience hypothesis. You wanted treatment that is both preventive and therapeutic at the same time,
Right.
right? This brings me to the next topic that I wanted to cover, anti-inflammatory drugs.
Mm-hmm.
You may have heard of a recent paper that made the rounds in all the longevity circles, describing that neutralizing antibody against interleukin 11, which is an inflammatory molecule,
Mm-hmm.
extended the lifespan of mice for around 20 to 25%. Now, the treatment also produced weight loss by reducing body fat while preserving muscle. And an interesting thing is that at the time, the scientists working on these antibodies were interested in fibroinflammatory diseases. They wanted to have a treatment for fatty liver disease or for pulmonary fibrosis. You just mentioned that Immuno has potential in many diseases associated with immune system dysfunction. So perhaps, I guess there are also plans to target these fibroinflammatory diseases, correct?
Yes, there are. And in fact, we've noticed in preclinical studies that Immune decreases fibrosis within muscles. And that's a naturally occurring age-related disorder caused by immune dysfunction. And we reverse fibrosis. But it's worth commenting on the IL-11 neutralizing antibody work. First of all, I applaud the scientists that did that work. I think it was very rationally done, very good work. IL-11, it's a ubiquitous cytokine and it's linked to chronic inflammation. It's known that inflammation is associated with an all age-related pathology. So thus, theoretically, neutralizing IL-11 system should have beneficial effects on inflammatory mechanisms related to age-related diseases like fibrosis, sarcopenia, and autoimmune diseases. So I think the rationale is correct. The authors assume that IL-11 is a pro-inflammatory molecule. However, that statement is controversial as it's shown by others that it's actually an immunomodulatory molecule. And maybe I'm geeking out a little bit too much there, but that's one thing. Still others believe that IL-10 is actually a response molecule to inflammatory cytokines. So the neutralization of IL-11 and it may be downstream effects that are shown in the literature to benefit inflammation, fibrosis, metabolism, and other aspects related to senescence. It might be inconsequential to those downstream effects. It may be key to those things, but we don't really see that from the published study. However, the approach using neutralizing antibodies doesn't address the causality of the inflammatory condition resulting in the IL-11 increase. Possible adverse events such as, of this therapy are not discussed. And, when you knock out IL-11, you would be thinking that you'd be, your side effects could be allergic reactions, drug resistance, etc. So there's some more work to do. I don't mean to denigrate the work. I think it's fabulous work and needs to be run down, but there's a lot of unknowns. And just as a gut response as a scientist, I do know that the immune system has tremendous redundancy. And knocking out any one thing, although you would like to do it because every drug you've ever taken knocks out one thing, right? The whole of scientific endeavors and research is about knocking out one thing. But the problem with knocking out one thing with single target antibodies like this one, or single target small molecules, other approaches, is that there's redundancy in the immune system like nobody's business, like no other organ in your body. It has tremendous redundancies with 5 or 50 things pushing and 5 or 50 things pulling for every physiological norm. So when you overdose and you whack down IL-11, it is such a ubiquitous molecule in many, many systems, you're definitely going to see some effects. And here we are seeing, an enhancement of lifespan. That's extraordinary. But how it does that, what the side effects are, could it be done in humans? There's quite a ways to go. Imuna is shown to reduce several families, interleukins included, of pro-inflammatory molecules. So the immunomodulatory mechanism of Imuna is attributed to multiple mechanisms, and we know that. So Imuna, by its multi-factor signaling nature, it's derived from young, healthy cells. So therefore, it may impact the general health of the adult cells and stimulate many, many tissue regenerative niches. So Imuna is working upstream of an isolated pathway like IL-11 and would benefit multiple mechanisms related to senescence and degradation. And we see that with epigenetic studies where we treat with Imuna, not treat with Imuna, and look at how the genome is being changed. And what we see from epigenetic analyses is that Imuna is causing a very broad spectrum anti-inflammatory and pro-regenerative response, very broad spectrum. And that works. I'd love to see if the IL-11 does that in a broad spectrum manner. It's clearly doing something broad spectrum, which is to be expected, as it is a very ubiquitous key molecule in inflammatory work. So I see it as not a challenge to our work. I see it as highly complementary in that knocking down the immune system or some pro-inflammatory component of it is having a benefit. Both studies both show that. Now we just need to see with both of these things, Immunis's as well as theirs, whether or not it translates to humans, whether or not it keeps translating, whether or not it's safe, whether or not it's commercially scalable, whether or not the cost of the drug production and anti-drug effects from the human, which frankly are a concern with antibodies, whether they can be overcome with another way of targeting IL-11, et cetera. So I'm cheering them on from the sidelines and looking forward to seeing all that data come out. But it's a great start.
So to summarize, since the immune system has multiple redundant pathways, what a good strategy with the immune system is to target upstream modulators and then right. to maybe regulate the whole immune system instead of a specific downstream pathway.
Exactly. Yeah. When you start knocking out a very particular molecule, you worry that if that molecule is ubiquitous, if it's expressed in multiple systems like IL-11 is, you worry that although you may see benefit in some physiological manifestation, like health span, lifespan, you may see detriment in another physiological manifestation where IL-11 or some similar molecule is working. So a ubiquitous system is difficult, and in the immune system, there is no system without redundancy. So, being upstream, I feel safer with that because we're massaging the immune system with 440 touch points. And rather than knocking something down, we see a general immunomodulation. So I'm very happy with where Immunis is at right now. The data certainly look very good. And I can only wish similar successes with the IL-11 team.
I have to ask, are there any plans to use Immuno in lifespan extension studies in mice, obviously without derailing all the clinical progress in health span?
Yeah, no, of course. Probably not in that it's a strategy. A study on mice looking at lifespan is particular to mice, but it can't be done in a human. Like there's no way in a practical manner you could ever replicate that in humans. Give a drug like Immuno or IL-11 antibodies to a bunch of humans and see if they live longer. You can't do that because the United States FDA does not recognize, lifespan as a outcome measure. So you can't run that clinical trial. And then secondly, it would be prohibitively expensive because you have to dose for how long? You don't know. So
Definitely.
indefinitely, yeah, like humans live a long time. So you can't do that study. You can't, let's back up. You can't even raise the money for that study because the people giving you the money will say, well, how long is your clinical trial? I want to see a budget. And you have to say, I don't know. I don't know when the control group is going to die. And so you have to, in a practical sense, measuring lifespan does not make any sense in the clinic. And it does little to develop a drug, even preclinically. It's very cool and it portends some kind of positive effect, but human clinical processes demand a functional outcome measure that's helping the patients, usually disease related, like we picked one of the manifestations of aging, muscle atrophy. 100% of humans get it. And so we're looking at that instead of aging. Another one would be metabolism. That's another manifestation of aging. Well, we can measure metabolism in sarcopenic obesic patients, for example, like we're going to do. But you can't measure longevity. So no, we won't ever be doing longevity experiments in animals because they don't inform a human clinical trial. And that's really where we want to be focused on is we'd like to be helping the humans.
Absolutely. I mean, these experiments are nice to read about, but are really not practical in drug development.
Exactly. And no negative on them. Like this was done by some academics in the laboratory. So they are not versant on clinical trial strategies and pathways. And if it is in ignorance, then that's fine too, because it is cool and it does show something and it's worth pursuing. So they did their job in saying, hey, look, world, this is worth pursuing. And I believe it is, so let's see what comes of it when it's put to the, other preclinical models of manifestations of aging that could serve as preclinical evidence to support a human clinical trial. When they get to that stage, it's going to be even more exciting when, although this paper is a lot more fun to read and gets a lot more press, longevity, life extension, it doesn't mean anything for the clinic. So I'm personally more excited by the translational work, the work that truly translates into human clinical trials and human treatment and alleviation of suffering. So let's keep our eye on that stuff. And I think we're going to be developing drugs at a more rapid pace.
Now, talking about translational work, this is a good point to introduce XPrize.
Yeah.
The XPrize competition, for a little bit of context, is literally a competition, a prize, where the winner will be awarded $101 million for reversing aging by 10 years in at least 3 categories. one, muscle function, two, immune system, and three, cognition. Immunome directly addresses the immune system and muscle function with the same treatment. And we briefly touched on the importance of the immune system in chronic inflammation in general, and obviously in neuroinflammatory diseases. Can we maybe talk a little bit about the effects that you expect Immuna to have at the level of cognition in terms of neuroinflammation?
Absolutely. You know, when I read the call for proposals from the XPrize, Jose, I thought, wow, did I write this? It seems like it was perfectly positioned for this endeavor. So, you know, Immuna can potentially improve cognitive function and slow the progression of cognitive impairment by modulating the immune system to reduce neuroinflammation. We already know that it reduces pro-inflammatory responses, you know, everywhere in the body. And that's if you take the blood, you can see that even in the humans, we're seeing that the level of pro-inflammatory response of those humans in their 70s are dropped half. That's like a human in the mid 40s. So, and remember, blood goes into the brain. So all your blood circulating goes through every organ in your body. So now we know in the rodents and we know in humans that we are bathing their brains in a immunomodulatory soup, Immuna. And we also know that every human has pro-inflammatory inflammation in their brain. You have to have it to get Alzheimer's, Parkinson, MS, cancer, etc. And so theoretically, we should see tremendous reduction of pro-inflammation in the aged brain. So that is known. There's published evidence supporting that by reducing inflammation, you can prevent neurodegeneration and psychiatric disorder. That's cognition wrapped in there. So there's a gap because we haven't specifically looked at it, but we know we can drop inflammation in the brain, and we know that when you drop inflammation in humans, you do prevent neurodegeneration and psychiatric disorder. So I do believe very strongly that we are going to see improvements on cognition in multiple ways. And so we have some years in pursuing this XPrize in order to do that. And I can tell you that we've already started in rodents and things look pretty positive, but it's early days so far. We've been concentrating on muscle and metabolism, but we will definitely be moving on to the brain as we have registered for the XPrize. And I just, you know, I grew up looking at that XPrize and seeing what it did to bring the private space industry into what was only government. And look what's happened. Look at how many private institutions from, you know, SpaceX and Virgin and everybody with, you know, several $billions is throwing rockets into space now. Well, that's enhancing the entire field. So I'm a really big fan of XPrize and what Anusha and Peter have done to generate this. And I'm just absolutely honored and delighted to be an applicant.
Yeah, indeed, it's basically bringing together all the leaders in a field toward a common goal. And this is obviously a constructive process. It's a competition, but it stimulates, it catalyzes the field
Sure
forward.
does. Yeah. You know, and we're to your point of catalyzing and stimulating collaboration and advancement, you know, for that XPrize application, Immunis partnered with the largest immunological endeavor in the world, the Human Immunome Project. So very, very proud to have a co-applicant there. So it's actually the two of us applying for this $101 million prize. The Human Immunome Project is like the Human Genome Project, which, you know, decoded the human genome. The Human Immunome Project, now that the Human Genome Project is finished, the human genome is fully sequenced. The Human Immunome Project has been born, and it is the largest endeavor in immunology in the world. And what it's doing is going to decode, you know, sequence, so to speak, the immune system in every single human population. We know so little of the immune system. Decoding it is paramount to drug development. What kind of drugs? Every kind of drug. because virtually every manifestation of aging or disease or injury involves the immune system. So if we can decode it, that means we can identify targets of intervention. And the Human Immunome Project will be the largest discovery of new targets for medicine than any endeavor ever in the world by orders of magnitude. And if you can identify targets, that means you can make diagnostics and you can make therapies. So there will be an enormous medical advancement with new diagnostics and new therapies, which also means an enormous advance of the biomedical industry worldwide. And remember, Human Immunome Project is doing this in all nations. So all nations are going to benefit. So we're very excited about it. It should reduce global healthcare costs and national healthcare costs, of course, but also stimulate industry and, you know, better humans.
There are actually some studies calculating the economic benefit of compressing morbidity for only a few years. It's billions of dollars.
Billions of dollars, yeah. Yeah.
And wrapping up, you were recently awarded an honorary PhD by the University of New Brunswick. Congratulations again.
Thank you.
And you delivered the university's 195th commencement speech. That must have been fun. So, so what are some of the key messages that you hope the graduates will remember?
Oh, you know, thank you, Jose. That's very kind of you. You know, I was so honored to receive such an award and be selected to give a commencement address. And let's see, I think my message to the graduates could be summarized up as people. Every pivot, every motivation, every inspiration comes from individual relationships with people. People are everything. And when you respect people, when you make yourself open to people, vulnerable to people, excited and fascinated by people, you have a wellspring of motivation. So go like somebody, go love somebody, and tap that spring.
That's a great message. We are indeed social creatures, humans.
Yeah.
So thank you again for taking the time to talk with me and all the insights. I think this was a very interesting conversation.
Thank you. I really, really appreciate the you know, the opportunity to get the story out there. I'm as excited as everybody is about this, and just really honored to be playing a role in moving this program forward, honestly.
And we look forward to what the future holds for Immunis.
Thank you, and thank you. Thanks to quadraScope for all the support.
Hello again. If you found this video interesting and would like more people to see this kind of content, consider clicking the like button and subscribing to our channel. Thank you for listening.